decreasing the HDL cholesterol level through TLC and even combination lipid-lowering therapy in high-risk patients. BC returns 2 months later for follow-up, reporting adherence to his new antihypertensive regimen and a low saturated fat, calorie-restricted diet with the inclusion of a wide variety of fruits and vegetables and soluble fiber sources. He also reports a brisk walking exercise program without his dog, but confesses that he may not be able to keep up the new diet much longer. Fortunately, he is still not smoking. His weight is 228, blood pressure is 138/86, and fasting lipid profile has modestly improved as follows: total cholesterol 211, HDL cholesterol 37, LDL cholesterol 146, and triglycerides 129 milligrams per deciliter. Given BC's current lipid panel results, which of the following is the appropriate next step for managing his dyslipidemia? The best answer is 2. Initiate rosuvastatin, 10 milligrams QD. BC's LDL cholesterol level is still far enough away from his goal level of less than 100 milligrams per deciliter to justify pharmacotherapy. Although therapy must be individualized to an extent, in most cases, initial drug treatment to lower LDL cholesterol levels should be with a statin, as the majority of evidence favors this class of medications. Ezetimibe monotherapy may be an option in statin-intolerant patients or when the LDL reduction goals are more modest. In general, neither fenofibrate nor niacin will lower LDL cholesterol levels as well as statin treatment, and neither choice has demonstrated primary prevention of MI in clinical trials. This patient has some of the features of the study cohorts in the ASCOT-LLA and AFCAPS-TEXCAPS trials. In the ASCOT-LLA trial, 10,305 hypertensive patients aged 40 to 79 years received randomly assigned atorvastatin or placebo in addition to effective antihypertensive therapy. Patients had at least 3 other cardiovascular risk factors and cholesterol levels of 250 milligrams per deciliter or lower. The study was terminated earlier than expected after a median follow-up of 3.3 years because of significantly fewer primary events, non-fatal MI or fatal CHD with atorvastatin treatment. Significant improvements were also seen in atorvastatin-treated patients with respect to the following secondary endpoints: fatal or non-fatal stroke, total cardiovascular events, and total coronary events. There was no difference in mortality between atorvastatin and placebo treatment. At 12 months, the mean serum cholesterol level was lowered by about 50 milligrams per deciliter with atorvastatin. The AFCAPS-TEXCAPS study was a randomized, double-blind, placebo-controlled trial assessing statin treatment in more than 6,600 patients with average total cholesterol and LDL cholesterol levels and below average HDL cholesterol levels. These patients received lovastatin 20 to 40 milligrams daily or placebo, both along with diet recommendations for a mean follow-up period of 5.2 years. The composite primary endpoint of fatal or non-fatal MI, unstable angina, or sudden cardiac death was significantly reduced in those patients taking lovastatin. Secondary endpoints, including rates of MI, unstable angina, and coronary revascularization, were also significantly lower in those taking lovastatin. For BC, the minimum goal of statin therapy is to reduce the LDL cholesterol level by what percentage? The best answer is 3, 30 to 40%. In patients at moderately high or greater CHD risk, the ATP3 recommends initial therapy with a drug and dosage to achieve a 30 to 40% reduction in the LDL cholesterol level. This recommendation is based in part on the treatment regimens in the trials discussed, but also on the recognition that many patients who begin statin medication are not appropriately titrated to goal. To choose the appropriate statin and dosage to achieve this degree of initial LDL cholesterol reduction, it is worthwhile to review the results from the STELLAR trial. This is the most comprehensive head-to-head statin comparison trial to date. It was a multi-center, randomized, parallel group, open-label, 6-week trial involving 2,431 subjects. Patients had an LDL cholesterol level of greater than or equal to 160 milligrams per deciliter and less than 250 milligrams per deciliter, and a triglyceride level of less than 400. Rosuvastatin 10 to 40 milligrams daily was compared to a broad range of dosages of atorvastatin, pravastatin, and simvastatin. The primary endpoint of the STELLAR trial was the reduction in the mean LDL cholesterol level. Rosuvastatin 10 to 40 milligrams daily reduced this level by 8.2% more than atorvastatin 10 to 80 milligrams per day did, 26% more than pravastatin 10 to 40 milligrams per day, and 12 to 18% more than simvastatin 10 to 80 milligrams per day. All of these comparative reductions were statistically significant, with a p-value less than 0.001. The figure on this slide includes only data from statin doses in STELLAR that are currently marketed. When compared with the other statin regimens, rosuvastatin also improved secondary outcomes, including changes in HDL cholesterol, total cholesterol, and triglycerides levels. From 82 to 89% of patients taking rosuvastatin 10 to 40 milligrams daily, and 69 to 85% of patients taking atorvastatin 10 to 80 milligrams daily reached their ATP3 LDL cholesterol goal. The percentages of all patients who attained LDL cholesterol levels below 100 milligrams per deciliter at 6 weeks were statistically higher with rosuvastatin than with equivalent doses of atorvastatin or with equivalent or higher doses of simvastatin or pravastatin. At his 2-month follow-up, BC was started on rosuvastatin 10 milligrams daily and followed up again 3 months later. At that point, he had managed to reduce his weight to 221 pounds. His blood pressure was within the normal range, and there were some improvements in his lipid profile results. Ongoing reinforcement of treatment goals is likely to be essential to BC's long-term success. He should be congratulated for taking the steps necessary to improve his global cardiovascular risk, as well as reminded that his efforts should be maintained indefinitely. His lipid profile should be reassessed every 6 to 12 months to ensure that levels remain at goal.
This has been a CME certified activity.